Okay, let's dive into this. Welcome to today's explainer, where we're going to tackle a true, high-stakes medical emergency, status epilepticus. You see, when a human brain gets locked in a continuous state of seizing, literally every single second counts. Today, we're unpacking the exact, step-by-step medical protocol that healthcare professionals use to stop the clock, calm the brain, and ultimately save lives.
To map out our clinical walkthrough today, we're going to cover 5 stages. 1, defining the emergency. 2, the high stakes. 3, first-line treatments. 4, secondary and refractory care. And 5, general measures.
All right, Section 1, defining the emergency.
So status epilepticus isn't just your standard seizure. It's strictly defined as seizure activity lasting more than 30 minutes or a scenario where 2 or more seizures happen back-to-back without the patient ever recovering consciousness in between. That detail right there, lacking consciousness recovery during recurrent tonic-clonic convulsions, that's the critical red flag. It basically tells us the brain's electrical system is just not resetting properly.
Moving on to Section 2, the high stakes.
Because, make no mistake, this is an absolute emergency. During these prolonged seizures, the brain is firing completely out of control. It's burning through up to 250% more glucose and oxygen than normal. The fits absolutely must be controlled to prevent death and permanent brain damage. This is not a let's wait and see kind of situation. The stakes are quite literally as high as they get. Life, death, and permanent neurological function. We are in a sheer race against the clock.
Section 3, first-line treatments. For our initial weapons, our first-line options are the benzodiazepines, diazepam and lorazepam. Now, what's really interesting about this slide is the difference in how they're delivered. Diazepam is administered as a 10 milligram intravenous bolus, meaning it's pushed at a rate of 2 milligrams per minute, and then that's followed by fractional doses every 10 minutes. Lorazepam, on the other hand, can also be used, but it's given as a slow infusion. The chemical properties between the two are the key here, really. Lorazepam is less lipid-soluble, and that results in a slower redistribution within the body compared to diazepam.
Section 4, secondary and refractory care.
Treatment escalation follows a very strict pathway, which we've laid out in this tabular comparison showing all the therapy tiers together. We start with our first line, diazepam or lorazepam. If those fail, or once the immediate crisis is contained and a longer-lasting substitute is needed, we escalate to the secondary tier with medications like phenobarbital or phenytoin. And if the seizures just simply won't break, well, then we're forced into the refractory tier, deploying intense IV anesthesia like midazolam, propofol, or thiopentone.
Let's zoom in on those secondary medications for just a second. Phenobarbital is administered at 100 to 200 milligrams per minute, either intramuscularly or intravenously. These secondary drugs act a bit more slowly than our first-line options. But with phenytoin, there is an incredibly urgent clinical rule you have to remember. It must be administered intravenously in running saline only. It must never be mixed with a glucose solution because it will precipitate. It will literally form solid particles right there in the IV line, which is an absolute disaster in the middle of a code. And then we have the most extreme situations, the refractory cases where the brain is stubbornly refusing to stop seizing. To save the patient's life and brain tissue, medical teams bring in top-tier measures, heavy intravenous anesthesia. We're talking midazolam, propofol, or thiopentone. Depending on the severity of the convulsions, these might even be administered with cararization, which essentially paralyzes the muscles to halt the physical damage, while the anesthesia goes to work on calming the brain's chaotic electrical activity.
Finally, Section 5, general measures.
So the crucial point is this. Without these basic life support measures running continuously in the background, the emergency drugs just cannot do their job. The medical team must ensure the maintenance of the airway and provide continuous oxygen. They have to carefully manage fluid and electrolyte balance, maintain a stable blood pressure, ensure euglycemia, and keep a normal cardiac rhythm. This is the bedrock of the entire protocol. You can administer all the anticonvulsants in the world, but if the brain isn't getting oxygen or the heart isn't pumping effectively, the battle's already lost. We've just walked through the strict timeline, the massive stakes, and the powerful pharmacological arsenal used to combat one of the most intense neurological emergencies in medicine. When a patient enters status epilepticus, the countdown begins. Will you be ready to act against the clock to save a brain? I hope this explainer has given you a rock-solid understanding of the emergency protocol. Please like, share, and subscribe our channel for more structured deep dives into critical knowledge. Until next time, keep learning.